Hi, everybody. Welcome to today's Winona webinar. I'm here with Dr. Green. My name is Angela. I work at Winona, and we are here with prospective patients who are interested in learning about Winona. And I want to turn this over to Dr. Green so he can introduce more about himself and talk to everybody about what we might learn here today. Dr. Green.
Hi, my name is Mike Green. I'm an OBGYN. And I am also the Chief Medical Officer of Winona. And for some of you, I may be your prescribing doctor, depending on where you live and who ends up taking care of you. We have currently have 9 board-certified doctors working for Winona, taking care of patients. So I'm one of them, but I sort of run the show. My background, I've been an OBGYN. I finished residency in 1999, so I've been doing this for a long time. And I've kind of seen the fall and the rise and fall and rise again of hormone replacement therapy. And so this has been sort of my passion. And it's something that I really enjoy, taking care of women. And unfortunately, the whole menopause thing is almost a taboo subject. People are afraid of it and they don't want to talk about it. And that's unfortunate because it's a real issue for people. And there's really good and safe treatment that can really be life-changing and make this time of life a really great time rather than something you suffer through. So I'm really happy to be able to help with that. Let me just say, the whole point of this is to answer your questions. So please type your questions in. This goes a whole lot better if I have questions to answer rather than me just kind of shooting my mouth. So please start putting in your questions. What I like to do is talk about a little something while you guys are putting questions in. So I thought I'd do that. One of the questions I've been getting lately from actually several patients is about the onboarding. And if you all have gone through the onboarding, it's pretty simple. It takes about 5 minutes, maybe less. And so some people love that, but some people question. It's like, well, how are you able to safely and effectively prescribe me medication based on this quick little onboarding? And so let me kind of go over that. When I go to a new doctor's office, they always hand me this giant book of paperwork that I've got to fill out. And, I get it, but some of it's ridiculous. And so when I designed this, I'm the one that designed the onboarding. The goal really was to ask everything I needed to know to be able to do this safely and ask nothing that I didn't need to know. So there's all kinds of information about your medical history that everybody asks you that nobody's ever going to use. So honestly, I don't really care if you had measles when you were 3. It's not going to change whether or not I'm going to be able to prescribe you medicine or what medicine I'm going to choose. Or if you had ankle surgery when you were 16, because you fell when you're playing volleyball, that's not really going to affect the management of what we're doing. And so instead of asking you all this esoteric stuff and you'll be spending a half an hour or an hour filling out all these questions that really aren't useful. Really tried to pare it down. What do I really need to know and not ask anything that I don't need to know? And honestly, it was kind of a paradigm shift for me. It took a while to figure out how to do that. And I think we've got a really streamlined thing that's super easy for you, but gives all the information we need to safely prescribe hormone replacement therapy. One of the nice things about what we do is that we do very little. We do one thing. We prescribe estrogen, and progesterone, and DHEA, and we prescribe blossom cream, and that's it. That's our whole repertoire. And so it's like, do one thing, do it really well, and then don't mess around with things you don't do. And so we really only need to get information for that one thing to make sure that we do that safely. And so that allows us to do it pretty quickly and easily. And so it's less of a burden for you. The other thing that people ask every time they ask this, so I'm going to go ahead and cover it because it's part of the same thing. How can you prescribe hormone replacement therapy without doing labs? This whole lab thing with hormone replacement therapy is really interesting. There was a couple of years ago, there was an editorial in the New England Journal of Medicine, which is our top of the line medical journal, that I think the title was something like "Stop Ordering Labs for Hormone Replacement Therapy." It's just not necessary. It's a complete waste of money. It's a waste of time for you. It doesn't help us. Hormone replacement therapy is really best done based on your symptoms. So we figure out what your symptoms are, we come up with a treatment plan, we see how that treatment plan works for your symptoms, and then adjust it as necessary to get you feeling better. My goal is not to make your labs look good. My goal is to help you feel your best. And what the laboratory report shows doesn't really help for this particular thing. There are some medications where we really do need labs. Thyroid, for instance, is a little bit more tricky because the symptoms are subtle, but there's some behind the scenes things that are going on, and you really need labs to adjust that correctly. But estrogen and progesterone don't work that way. First of all, the labs are really inaccurate. So the hormone levels in your blood vary from day to day, they vary from hour to hour. And so if you eat a big meal, it can change. It depends. Did you do this when you woke up? Did you do this in the afternoon? Were you stressed? And so the numbers that come out on these pieces of paper aren't really very meaningful. And so using those numbers to guide your hormone replacement therapy actually gives you a worse result than just asking what your symptoms are and doing it based on that. And one example I like to use is I have high blood pressure, so I'm on blood pressure medication. We follow my symptom, which is my blood pressure, and adjust my medicines based on my symptom. So nobody draws a lab to see if my beta blocker level is okay. They look at my blood pressure. That's my symptom. And if my blood pressures are too high, then we need to add more medicine. And that's the way it goes with hormone replacement therapy. What are your symptoms? Are your symptoms being taken care of? Then we're good. Are you having symptoms? Maybe we need to add a little more medicine. And so that's how it works. And so that's a really common thread and a really common question. Unfortunately, labs has become a big moneymaker for lots of people out there. And so they're sort of pushed. There's, websites that do these online labs, with saliva tests and different things. And, they're $1 billion industry, and they're trying to tell you that you need this. You don't. A lot of the doctors' offices own their own labs, and they're making a lot of money off the labs. And quite honestly, we could do that too. We could draw labs that we don't really need, makes you feel better. We can make a bunch of money off of it, but that's not what we're about. We want to do the right thing for you. And so we try to make this super easy for you, very convenient, but with all the information we need to do this safely. So that's kind of how that works. If you're questioning why is it so easy, it's because that's how it's designed, and that's the whole point. But believe me, I'm getting the information I need. And every now and then, there's something that comes up, and me or one of the other doctors will ask you a question, and there'll be a little back and forth to get more information. And so, that does happen from time to time. But most of the time, the information we gather from the online interview is really everything we need to know to do this safely. Okay, enough of me rambling on. Hopefully we got some questions.
We do. Okay, our first question is, do you ever prescribe oral compounded progesterone instead of the cream?
So the answer is no. The progesterone is interesting. So this is another one that I've never really been able to figure out, but there is this thing out there that people really only need progesterone, they don't need estrogen. And it's kind of backwards world, because it's really estrogen that does the heavy lifting in taking care of your menopause symptoms. And so it's estrogen that's really the primary medicine that's going to take care of your symptoms. The progesterone is used primarily just to protect the uterus from the estrogen. Because if someone still has a uterus and you give estrogen without progesterone, it can cause problems. When you add progesterone back, it actually makes things safer than if you didn't have it in the first place. So progesterone is primarily used really as an adjuvant. It's to keep the estrogen safe, but the progesterone itself it's doing some, but it's really the estrogen that's doing the heavy lifting. As far as the oral compounded medicines, there are people that sell these truches where you dissolve them in your mouth. And the problem with that is the absorption's kind of wonky. You get a very big spike of hormone, and there isn't really a big advantage to that over just a standard pill or a compounded cream. Compounded creams have a big advantage as they bypass the first pass metabolism, so that when you swallow a pill, that pill goes straight to your liver and then goes to your blood system. When you use a cream, it gets distributed throughout your body before it goes just to the liver. And so there's some advantages with that. So for the oral progesterone, we use what's called micronized progesterone. It's a bioidentical progesterone, but it's in a capsule pill form. But we also have progesterone creams.
Our second question is also about creams. It wants to know, the question asks, are your estrogen/progesterone creams available in different strengths? If not, what is the dose that we prescribe?
So yes, we have a variety of strengths, and so when you onboard, there's an algorithm that I built that, number one, offers you what we think, what the algorithm says will probably work for you, and then what you don't know is that on the other side, there's an algorithm that suggests a dose for the doctors, and so that dose is based on a bunch of different things: your symptoms, your past medical history, the medicines you're on, your BMI. There's a bunch of things that go into this, and it gives us a suggested dose. We have a bunch of different doses available. The way I built this is that most of the people I get right on the first shot, so that dose works really well, but I purposely undershoot just a little bit. So my philosophy is that I would rather have to sort of titrate up so that you're okay, it's helping, it's not quite helping enough. Okay, let's add a little bit more medicine. I'd rather err on that side than hit you with too much and all of a sudden you're having side effects and you feel lousy, because I don't want to make you feel worse. So there are different dosages. We start off with a recommended dose based on this algorithm that I built over about the first 1,000 patients that we had with Winona. And it works really well. And again, every now and then I overshoot, but for the most part, I get it right, or maybe have to add a little bit down the line. So that's how the dosages work.
Okay, our next question asks, 10 to 12 years ago, I had 2 biopsies that revealed atypical ductal hyperplasia. I've been fine since, monitored every 6 months with mammograms and breast MRIs. Should I even consider HRT?
So I would not prescribe HRT at Winona for you because you have a high risk of developing a breast cancer. And so I think that's probably a mistake to do that and push that risk a little bit more. That being said, there is an argument for what you have, and since you've been disease-free for so long, that it may be safe. But that's something I think that would benefit more from a really face-to-face sit-down conversation with your doctor to discuss what the risks are, have your records from your breast surgeon, your oncologist, whoever's taking care of that, and really coordinate care. And that's really kind of more than we can do at Winona. So my goal here, number 1, 2, and 3 is safety. I don't want to hurt anybody. And so we, a little bit cherry pick, and we really kind of go the extra mile to be super safe. There are patients that I might prescribe in my office that I wouldn't prescribe on Winona for that reason. Obviously, we also want it to work, and we want to make you feel better. But if I hurt you, if I take away your hot flashes, but I give you a breast cancer, I haven't done you any favors. So I think, unfortunately for you, you'd be a little bit too high risk for this situation. But, a sit-down conversation with your OBGYN with all your notes from whoever's been taking care of your breast abnormality, may be reasonable.
We have a question from Madeline who asks, is it possible to get progesterone in pill form? And why is the estrogen patch more expensive than the cream? Is the estrogen patch also made from yams?
Okay, so 3 questions, and all 3 good ones. So it is possible to get progesterone in pill form. And so if you still have a uterus and you need progesterone, if you're on the patch or if you're on the estrogen pill, then we would add generally a progesterone pill. If you're on the cream, we usually compound the estrogen and progesterone together because it's a lot more convenient and cheaper because it's one price. The interesting thing about the cream, and this was a surprise for me when we started doing this, is that most of the cost in the cream is from the base cream itself. The medications are actually not that expensive. And so the cream's the same price whether you have just estrogen or just progesterone or a combination of estrogen and progesterone, because our costs are really in the base cream. And so that for me was kind of a surprise, but that's the economics of it. Which leads us to the question is, why is a patch so much more expensive than the cream? And the reason why is that we compound the cream ourselves in our pharmacy with our pharmacists using base chemicals. So The overhead, we have to buy the cream, and then we have to buy the estrogen and the progesterone and mix in the cream. But surprisingly, those medications in bulk form to put in cream is fairly inexpensive. Cream costs a little bit, but not that much. And so then it's, the expertise of our pharmacists, and we have the best compounding pharmacists in the business. These guys are amazing. And it takes time to do this, and that overhead. But so the overhead of the cream is a lot lower. The patch we have to buy from a manufacturer that manufactures the patch, sells us the patch wholesale, and we pass it on to you. But because we're not basically manufacturing it ourselves or making it ourselves, there's a lot more cost in the patch than there is the cream. So we try to keep costs down. We try to make this as affordable as possible. And we recognize, in fact, when people ask me my advice, I always say, if it was me, and in fact, for my wife, use the cream because it's the cheapest. And they all work great. And so, the cream is so much less expensive than the patch. I don't understand. Some people like the patch and they're willing to spend the money. That's fine. But I'm a cheapskate. I wouldn't, because the cream works so well. But that's the reason. It really just comes down to our costs. Since we're compounding the creams ourselves, it's a lot less expensive for us than buying the wholesale patches. And yes, the estrogen in the patch is also yam-based, bioidentical.
Dr. Green, I want to add on to that question for a second about the patch. Is there ever a time where the patch is of benefit over the cream or the pill?
So some people think so. I don't. It always used to crack me up in the office. Why do people want the patch? To me, and it's a personal thing, I think it'd be really annoying to have to wear a patch all the time. Patches, they work great. And some people like the convenience of only having to slap one on every few days. And you can put it on and forget about it. And so I get that. For me, I think it would be obnoxious to wear a patch all the time. And honestly, for me, it's a lot easier to remember to do something every day than it is to do something every 3 days.
Right.
So I think I would forget. Although I guess if you're wearing it, you probably don't. But
right.
So the advantage of the patch is that you only have to deal with it every few days. There's a theoretical advantage. Well, the advantage of the patch over the pill is, again, that first pass metabolism. So there's some theoretical safety in using things through the skin rather than taking it in a pill form. And it has to do with the way it's metabolized through the liver. And so it has a lower effect on your lipid profile. It's gentler on your liver. It also, in theory, has less clotting issues. So there are some reasons why what we call transdermal approach, which would be through the skin, would be advantageous over the pill form. And so that would be an argument for the patch. However, the cream gives you those same advantages. And so when you compare the cream and the patch, to me, the cream seems more convenient to me. But again, everyone, that's a personal thing. And that's why I tell people they all work great. It really comes down to cost and personal preference. So I don't think there's any medical big benefit to the patch over the cream. There can be of those two, of that category, over the pills. And so, would you rather have a patch on all the time and only have to change it every few days, or would you rather rub a little cream on you every night or once a day?
Yeah.
That's a personal preference thing.
Awesome. Well, that's super helpful. All right. So the next question we have, Krista says she's still getting periods, super heavy, and she's become anemic. Her hemoglobin is a 9, and her gynecologist tells her to take iron. But she feels that she might need another opinion. What are your thoughts? She's been on Winona for quite some time and loves it.
So I assume, and I guess I shouldn't, that your OB/GYN has done some kind of workup for your bleeding. That's not normal to bleed so much that you have a hemoglobin of 9. So that's dangerous and not normal, and hopefully has been evaluated. The most common reason for that is, I don't know, you're bleeding. But there are some things that, number one, can be fixed, and there's some things that are potentially dangerous that need to be, make sure that's not why you're bleeding. So I would assume, I'm hoping that you've had an ultrasound, maybe even an endometrial biopsy. And so once you've had the appropriate workup, and it's like, okay, we've ruled all the dangerous stuff, and this is, I don't know, you're bleeding, that sucks, sorry, but it's not dangerous. So as a physician, this is a broader topic than Winona, but when a patient comes to my office, my first job is, sick or not sick, do I need to send this patient to the emergency room, or is this a patient I can take care of in my office? And seriously, sometimes that's a really important question, and dangerous or not dangerous. So when somebody has a problem, I need to prove that it's not something that's a threat to them that's dangerous. I need to, either it's dangerous, we need to fix it, or this is annoying and we need to take care of it to fix the annoyance. But the way you fix those two problems are very different. And so the first thing in somebody that's bleeding so much that they're getting anemic is, is there something dangerous going on? So that's number one. And then number two, is there something structural that doesn't require medicine, requires surgery or a procedure? Is there a fibroid? Is there a polyp? Is there something that physically needs to be taken care of? So if that hasn't been done, that needs to be done. So I'm assuming your OB has done that. If they haven't, you either need to go back to your OB or find a new OB, because that's the primary thing. So let's assume that that's been done. And now we've ruled out all the dangerous things, and you just have what we call, so the medical term for that is dysfunctional uterine bleeding, which is kind of a funny name because it's like, it is what it is. It's dysfunctional uterine bleeding. I don't know why, but you're bleeding, it's dysfunctional, and it's nothing dangerous, but we don't know why. And it's usually a hormonal issue. And so that needs to be controlled, because it's not good for you to be bleeding down to a hemoglobin of 9. Iron is definitely part of the treatment, but all iron does is give your body the ingredients it needs to make more blood, because you're losing so much blood. But when something's leaking, you got to fix what's leaking. So yeah, we can help fill it back up with the iron, but we also got to fix the leak. And so there are medicines that can help with the bleeding beyond hormone replacement therapy. Hormone replacement therapy isn't the best medicine to fix this kind of heavy bleeding problem. It's great for the symptoms of the menopause transition, having hot flashes and night sweats and brain fog and weight gain that you didn't used to have, and all joint pain and all these things that go with the menopause transition. Hormone replacement therapy works better than anything else, but it's not the best treatment for dysfunctional uterine bleeding. There are better things for that. So, and that's not really something that we provide particularly. Sometimes HRT can help with that, and it'll kind of take the edge off, and sometimes enough that it'll keep you safe. But if you're still bleeding to a hemoglobin of 9 and you've been with us for a while, that's really more than what Winona is going to do for you. And that's something that really should be taken care of with your OBGYN. So I know that's not the answer you want to hear. But again, I want you healthy more than anything else. And, you got to make sure that this bleeding is taken care of and that you've ruled out a dangerous thing. So I think that's really important for you.
It's also really important, I think, for a lot of people who just dismiss, oh, that's part of perimenopause or that's part of menopause. I don't know if that's a common thing that you hear a lot of from patients that are starting and they're having irregular periods with excessive bleeding, but there's a tipping point where the excessive bleeding turns into a medical issue versus just a symptom of perimenopause, because lots of women have heavy periods, right, in their perimenopausal phase where everything goes a little haywire.
I can tell you that it's not unusual for me to admit a patient into the hospital who's bled so much that we have to admit them and give them blood transfusions, because they've gotten into real trouble, and they come in, they're passing out, and they're in real true medical emergency, and we have to bring them in and give them a bunch of blood to fill their tank back up, but also figure out why they're bleeding and stop the bleeding. So it's not something you want to blow off. And unfortunately, and this is really unfortunate, but a lot of doctors we'll do that. It's, oh, this is part of life. You'll get through it. Well, no, that's not a great answer. So yeah, it really deserves to be taken care of.
All right, our next question, Dania, actually she has two questions. One is, how do you know if you need DHEA? And the second is that her OBGYN is trying to talk her out of bioidentical hormones in favor of an estrogen patch and a progesterone pill. So the question is, how is Winona's product different than that?
So let's start with the DHEA. So DHEA is a supplement that as soon as you take it, within 30 minutes, the body breaks it down into estrogen and testosterone. And estrogen, you don't get that much estrogen out of it, but we're really using it for the testosterone. So one of the hormones that falls in the menopause transition is testosterone. And, testosterone is always thought of as the male hormone, right? This is what these big bodybuilders use, to get huge and all that stuff. And we're not talking about that. And people, so I'm in the gym, I lift weights, and I've got a lot of friends in the gym that are these big guys that, that juice. I don't, but some of my friends do. And DHEA is one of the things that they use, muscles, but they use these huge giant mega doses of it, not the kind of doses that we're doing, but it works, and in fact, in some, if you're a professional athlete or you're a competitive athlete, some of the sports actually test for DHEA. So, we've had some patients that can't use a DHEA because it's a banned substance in their sport. So it's a substance, it's something that works. And the problem with it online is that you have these people taking, mega doses of DHEA as a performance enhancing drug. And so when you do that, there's a lot of side effects. So you go online and you see all these scary side effects that people have had from the DHEA. We're using it in really small doses, 25 to 50 milligrams. And in those doses, the DHEA gives just enough testosterone to get you back to that sort of normal female level, but not so much to turn you into, Miss Arnold Schwarzenegger, So you're not going to win bodybuilding contests because of the DHEA we give you, but you are going to get the testosterone boost, which can give you a lot of benefits. So it can help with weight loss, particularly the weight around the middle. It can give you more energy. It can help with libido. So DHEA can be a really nice tool. There are doctors that use testosterone, either creams or injections or pellets, and those work. But with adding actual testosterone, you have to be really careful not to push it too far, or you start getting what they call sorry, now I can't say the word. They're going to turn you, giving you male side effects, basically. And so if your testosterone gets too high, you start getting facial hair. You can get male pattern baldness. You can get a deepening voice. You can get chloromegaly. There can be all kinds of problems, acne. DHEA in small doses isn't going to get you there, and that's one of the nice things about it. It's a very safe way to give you a little testosterone boost, to give you the benefits of testosterone without all the side effects. And so the way I know whether you need DHEA is by looking at your symptoms. And so if you have symptoms that are from not enough testosterone, DHEA is going to give you the boost to help with those symptoms. So that's the main way that I decide whether DHEA is something to add to your regimen. Do you have just sort of pure estrogen symptoms, or most people have a mix? Because when you go through this transition, what's happening is the ovaries are becoming much less efficient of making the hormones that your body needs. And so estrogen is the primary one because that's the primary female hormone. But testosterone is also important, and that also drops. And so a little bit of testosterone boost can be really helpful. So that's, a little bit about DHEA and why we use it and how we use it. And the second question
was about
how do we differ from what your OB wants to give you? Well, we may or may not differ. It depends on what pill and patch that your doctor wants to use. So we have pills that are bioidentical. We have patches that are bioidentical, but they also have pills and patches that are not bioidentical. So the most common estrogen for a long time was something called Premarin. And Premarin is basically it stands for pregnant mare urine. Premarin, that's where the name comes from. And so what they do is they have these these stables of horses, and they keep them pregnant, and they collect their urine. And pregnant horses have a ton of estrogens in their urine, and then they spit them down and they get the estrogens out of the horse urine, which isn't a problem itself, except that horses make a lot of estrogens that humans don't make. And so Premarin has, I don't know, I forget how many, but it's in the teens of different hormones. Most of them aren't human hormones. And so, you get estrogen, but you get all these different estrogens that your body's not used to, and can give you a lot of different side effects and probably more risk than really just the bioidentical hormone, which means the hormones that your body actually makes. It's what your body's designed to use, and that's what a bioidentical hormone is. So Premarin is probably the most common one, but there are also synthetic hormones, and these are hormones where they make them in the lab. So, excuse me. Sorry, a little tickle in my throat. So these hormones, basically they have biochemists that use starting products, and they, in the lab design these hormone analogs. And these aren't bioidentical either. They're not exactly the same as what your body makes. And they have different side effect profiles. They work to some extent, but they don't work quite as well as a bioidentical, because again, it's not what your body's designed for, and they have more side effects. Pardon me. The story I like to tell, so the way this works, your body, the way hormones work, your body has receptors, and the hormone binds to the receptor. That sends a signal from the receptor to your brain and says, hey, this stuff's acting, you need to do something. And then your brain says, oh, there's estrogen on the receptor, I need to do all this stuff. And that's how hormones work. And these receptors, the analogy that people make is a key and a lock. So the receptor is a lock, and the hormone is a key, and the hormone fits into that receptor. And if it's a perfect fit, then it works and it turns the lock, and that sends a signal to the brain. There are chemicals or hormones that are not exactly right for the lock, but still sort of fit and sort of work, and you get some side effects from that. And so I like to tell the story. When I was in college, I had this beat up old Datsun B210. Got me through college. It was a great little car. It was kind of an embarrassing looking car, but it worked. And my best friend at the time, he had a Datsun 240Z. It was all souped up. He had like special carburetors on it, and he called it his Porsche eater, And the funny thing was, the key to my Datsun B210 would open the door of his 240Z. So I always would, I'd unlock his car door with my Datsun B210 key, and I'd say, hey, a Datsun's a Datsun. However, that key was not quite right, and it wouldn't start the ignition. So it was good enough to open the door, but not good enough to start the ignition. And that's kind of how I think about these synthetic and these equine or horse estrogens is, they give an estrogen effect, but they don't give the whole effect like a bioidentical hormone does. So that's a long answer for your question. Is how is what your doctor wants to give you different than Winona? And it depends. It may be that the pills and the patches that your doctor wants to use are the same that we have, and it's quite possible because the pills and the patches that we use, we do get from, they're bioidentical, they're manufactured, and they are available. However, the creams are compounded, and that's really kind of, in my opinion, that's kind of where we shine, because these are compounded creams that are made by our pharmacists in our pharmacy, and it's really kind of an art form, and these things work really well, and they're dosed specifically for you. We have a lot more leeway with them, and because we're making them, we can keep the cost down. So that's something that your OB probably can't offer you.
Okay, we have a question about family history of breast cancer. The question is, what is your stance on prescribing HRT for someone with a family history of breast cancer?
Great. So my stance is follow the science. So there's really good evidence for this, and that is that a family history of breast cancer is not a reason not to use hormone replacement therapy. So it's safe to use hormone replacement therapy, even with a significant family history of breast cancer. So, and even if it was even let's say your mom had a estrogen receptor positive breast cancer, it's still considered safe to use hormone replacement therapy. The caveat is, if you have one of these genetic factors, predispositions to breast cancer, it's probably not a good idea. So if you have a BRCA positive gene or a Lynch 2 gene or something like that, then hormone replacement therapy is not probably a good idea for you. However, a family history of breast cancer, even if it's a fairly close family member, hormone replacement therapy is safe and it's okay for you. So that doesn't disqualify you. And that's not just me, that's standard of care. That's what all big studies say. So you ask what my stance is, which is totally a reasonable question. And that's my stance, but that's why it's my stance, because it should be everybody's stance. Unfortunately, there's this history of hormone replacement therapy. It's kind of interesting. I'm going to go down a little rabbit trail. But back when I got out of residency in the late 90s, early 2000s, we were basically prescribing HRT to everybody. We thought it was like a vitamin. We were giving 80-year-olds HRT. And, we just thought it was good for everybody. We should be putting this stuff in the water. And then the Women's Health Initiative study came out and basically said, well, wait a minute, actually, this is a medicine and it has risks like everything else, and need to be more careful about who you're prescribing it to. Now, there were some real issues with the Women's Health Initiative study, but that was basically the big picture answer, and it wasn't wrong. The problem was, because hormone replacement therapy, I think it was the most popular prescription being written at the time, the newspapers came out with these headlines: hormone replacement therapy is killing women, it's dangerous, your doctor's terrible for giving you this, and everybody freaked out, doctors and patients alike, and everyone yanked the hormone replacement therapy away, and all of a sudden nobody was getting hormone replacement therapy anymore. And it was women really suffered from this, honestly. It was really not a good thing. But the headlines hit way before the details of the study, and by the time the details of the study came out, we realized that's not really what the study showed. And if we do it right, it's very safe. It was too late. And by that time, everyone was afraid of it. And so there was this whole generation of OBGYNs in residency at that time, and even after it, where they're in training, they were told, nobody's ever going to use this anymore. This is a history lesson, and we don't have time for a history lesson. So nobody got trained on it. Is true. There's so much to learn in medical school and residency that you're cramming your brain with everything you're going to need, because there's a lot to learn. And so you don't want to learn stuff that's not useful. And at the time, for a long time, people thought this wasn't going to be useful. And so there's no point training people. So there's this whole generation of doctors that never really got trained on hormone replacement therapy. And so they don't feel comfortable prescribing it because they don't know, they didn't get trained on it. They're afraid of it. They would sort of beat into them, don't give this to women, it's bad. And now, fortunately, the pendulum is starting to swing back, and we've got all this data. It's like, no, do it right, and it's very safe. But people are afraid of it. And so not only are they afraid of it, but they don't really know how to do it right. And that's a real problem. And the Kaiser system in California is I think it's the biggest health system in California. They pretty much don't prescribe hormone replacement therapy. That's kind of their blanket thing. Oh, we don't prescribe that. They have some stuff on the formulary, but it's not bioidentical, and most of the doctors just won't do it. And so that's, in my opinion, it's a big issue, and I'm glad that we're able to fill that gap. And I forgot why I was laying that ground, but
yeah,
I forgot what the question was. Where I was going with that.
Between the
What's that?
The differences between what's available and why people prescribe the BHRT versus non. And
oh, right. So yeah, and so people never learn the new stuff, really. I mean, BHRT is fairly new. Back in the day, Premarin was all we had, and then the synthetic stuff. But this BHRT is fairly new, and a lot of people just aren't educated on it.
Yeah. Our friend Dawn would like to know, are the hormones in the cream released over a 24-hour period like the patch, or all at once?
So the patch is actually released slowly over a 3 or 4 day period. And the hormones in the cream, you put the cream on once a day and they absorb into the skin, but then they slowly absorb into the blood system. So they're also sort of a delayed release, but not as much as the patch. The truth is, it doesn't really matter. So the thing about the hormones is they have what's called a very long half-life. So they don't get eliminated that quickly in the body. Drugs with a very long half-life don't need to be dosed as often, and you still get a nice steady state in the blood system. You may have noticed you've been on different medicines where some of them you have to take 4 times a day, and there are medicines where you take it once a month. And it really has to do with this idea of half-life. So with the hormone replacement, the half-life is long enough that daily dosing is enough. And so once you get into that equilibrium time, you get 3 or 4 weeks into this, there's really no advantage to sort of trickling the dose a little bit at a time or just getting a bunch of it once a day. So the patches do trickle the dose better than the creams, although the creams do it better than the pills. But the truth is, from what they call pharmacokinetics, which is how the drugs get metabolized in the body, it really doesn't matter once you've been on them for a while. So whether you're taking it once a day or whether you're trickling it over time, your drug levels are going to be pretty constant throughout the day. So that's one of the nice things about hormone replacement therapy is it's really a daily dose is fine.
Okay. We have a question about our favorite topic. Can you touch upon weight gain and bioidentical hormone replacement therapy?
So this is a really, I think, misunderstood thing in the public and even by doctors, honestly. And that is that hormone replacement therapy sort of has this bad reputation of making people gain weight, and it's just not true. So one of the things that happens in the menopause transition is that metabolism changes, and weight starts getting deposited in the middle where it didn't used to, and it becomes harder and harder to lose weight. And it has to do with the drop of the hormones that the ovaries are making. You used to have an hourglass shape, and all of a sudden now you got an apple shape, and that's not what most people want, and it's also there's some health risks to it. So if the weight gain that you're having is because of this hormone transition, replacing those hormones to get you back to normal youthful levels will help with this metabolism, make it easier to lose weight, and also easier to redistribute weight to get that weight out of the middle and back into a normal, healthier distribution. On top of that, one of the things that happens is it becomes more difficult to make muscle mass. And so one of the things that can happen through the menopause transition is that you start losing muscle mass. So not only are you gaining fat, but you're losing muscle mass, and that's a bad combination. And so ideally, you want to increase your lean body weight. Even more ideally, you lower your BMI, but you increase your muscle mass. And that's sort of what you're going for. Hormone replacement therapy makes that easier to do and helps with the metabolic changes. Unfortunately, it's not a magic pill. Some people take the hormone replacement therapy and they think they don't have to change anything about what they're doing, and they're just going to lose weight. And for most people, that's not the way it's going to go. You really still have to do the hard work. It's just that hard work is going to be more efficient, and it's going to give you more results than if you weren't on the hormone replacement therapy. The other thing is that one of the unfortunate things about hormone replacement therapy is that if you were going to get side effects, the side effects tend to show up early in the process, which is really frustrating. The benefits take a while to show up. So for a lot of people, they don't really start seeing the benefits of the hormone replacement therapy until a month or 2 or even 3 into treatment. But the side effects show up right away. So it's frustrating. You're all excited. You've been a little nervous about this. You researched it. You come to Winona. We give you your medicine and you start taking it. And in 2 weeks, all of a sudden you're 5 pounds up, because one of the side effects that sometimes happens at the beginning of treatment is water retention. That's temporary. It'll go away on its own, but it sure doesn't feel good to all of a sudden be swollen and have the scale laughing at you in the morning when you step on it. And it's really disappointing, and you're not really feeling any benefit yet. And that can be really disheartening. And so then people quit, and then they say, oh, hormone replacement therapy makes me gain weight. It's like, well, you didn't really give it a long enough chance. And so for most people, that water retention, if it happens, goes away, or bloating or whatever other side effect within the first month or so. And then that's when the benefits really start. So this is kind of This is a marathon, not a sprint. And you're really in this for the long term. And if you can stick with it, for most people, by the time they get to that about 3-month mark, you really chug along, you're getting all the benefits, the weight's starting to reverse now, and you're doing well. But it's hard to get to that point when you have a rocky start. The other thing is that, if you've been gaining, a lot of people will go through the menopause transition. One of the big things that happens is they gain a bunch of weight out of nowhere. They were always skinny, and all of a sudden they've gained 30 pounds in a year. It's like, how did that happen? And so there needs to be a reversal of that. So we're going to change the metabolism. We're going to make it easier for you to lose weight. You're going to do the hard work of diet and exercise. But you've got to stop gaining weight, and then you can start losing weight. It's like reversing, stopping a moving train. There's some momentum there that needs to be done before it's going to reverse and the weight's going to come off, and that takes time. And, patience is hard. That's the joke, right? I want patience and I want it now. And so this is and the other thing that's really frustrating for people, and I get this, is there are some people that are super lucky. They start the HRT and in 2 weeks, they feel great. And then they get on the Facebook page or social media. And so for you, that has the more typical thing where it's a little rocky at first and it takes a few months to really get all this benefit. You're reading this and you're like, well, this isn't working for me. But that's really, some people get lucky, but for most people, it's slow, steady progress. And you have to be patient with it. And if you hang in there and you're patient with it, for most people, it ends up being a good thing.
So we have a question that goes back to the estrogen progesterone topic, which is how long does it take to be able to sleep? Or I'm sorry, how long does it take to be able to work in your system if you're taking estrogen and progesterone to really be able to sleep? They've been taking it for 1 month.
So usually by a month, we're at that place. Remember I talked about this long half-life, which makes it so that once a day dosing works, but it also makes it take a while before you really get that drug level steady. And by a month, you should be getting to that point now. So the 1 month point is usually a pretty kind of good break point for people where the side effects are going away and the benefits are starting to show up. So you're kind of right there now. You should be over the hump, and you should start be seeing the benefits. The sleep is one of the things that HRT can really help with for a lot of people. But again, it kind of depends on why you're having difficulty sleeping. So if the difficulty you're having sleeping is because of the changes from menopause, you're waking up in the middle of the night with hot flashes or night sweats, or or other reasons, and sometimes it's not even that. It's just the hormones are not there, and you're not sleeping as well, and you add the hormones back and you sleep better. The HRT can really help a lot for sleep issues. If you have sleep issues for other reasons, you have sleep apnea, or you're so stressed out in your job and your home life that you're just sitting there thinking about everything all night, HRT may not be the right sleep remedy for you. So it'll fix what it can fix. So for the sleep issues that are because of the menopause transition, HRT is going to work really well at fixing those. But it's not going to fix everything in your life. It's not going to necessarily take all the stress away from work, or make your commute better. It may make it easier to handle, but there are other things besides your hormones. But it fixes what it can fix, and does a really good job of that. And at that month, you're kind of at that point now where I would expect you to start seeing some benefit.
Okay. We have a question that relates to perimenopausal symptoms. It says, I just started with Winona 2 weeks of cream and DHEA. I feel good, and I'm wondering, since I still have my period, does it help in slowing down premenopausal symptoms? I'm okay with still getting my period.
So yeah, there's kind of a little bit in that question. A lot of people there's this misconception out there that you're not supposed to start hormone replacement therapy until your periods stop, and that's just nonsense. It's completely backwards. So we know that hormone replacement therapy has a lot of benefit and a lot of long-term health benefits that are best if you start early. There's a cardiovascular benefit that you actually lose if you don't start before 60, and the earlier you start it, the more benefit you get out of that. And so it's completely appropriate to use hormone replacement therapy even while you're still having regular periods. And that's something that I get a lot of questions about. There seems to be a lot of misconceptions about that. And even doctors, again, aren't well educated on this and give bad advice about that. So it's totally appropriate to be on hormone replacement therapy while you're still getting regular periods. And in fact, really probably beneficial. It will help your perimenopausal symptoms, and that's reason enough to use it right there. But it also gives you health benefits as well. So I think that's what the question. I think that was what the question's about. Hopefully, I answered it well for you.
Okay. Our next question is from Michelle, who says, "I'm fortunate to not have hot flashes or night sweats. Yay. However, I do have major fatigue, weight gain, brain fog, achy joints, and muscles. Will the prescription I receive be specific to these symptoms I have, but not the others, such as hot flashes or night sweats? I'm afraid I may start getting those symptoms if I start taking Winona."
Good question. The answer is yes and no, and probably not. So let's start with the last part. So long-term hormone replacement therapy is not going to bring on perimenopause symptoms. It's not going to give you hot flashes if you never had hot flashes. There is a however to that. So one of the reasons people get hot flashes is the ovary becomes less efficient at making hormone, and instead of making a nice smooth amount of hormone, it kind of spits it out in spits and little bits. And those spikes in hormones are one of the things that can cause hot flashes. When you first start hormone replacement therapy in the first few weeks, all of a sudden your hormone levels are changing, and that can sometimes bring on hot flashes that you never had before. So this is something that people get mad at me about sometimes, is they'll write in, I never had hot flashes and I've been on this for 2 weeks and now I've got hot flashes. This isn't working. It's like, hang in there. This is a temporary problem. As the drug levels come up, your brain can sort of misinterpret that as a little hormone spike and give you a hot flash. So in the first few weeks, it's possible that you may all of a sudden get hot flashes you never had before. But once you get past that, no, it's absolutely not going to do that. The other part of that, and this actually happened to my wife, is that maybe you don't get hot flashes and you're on hormone replacement therapy and you're on it for a year or 6 months or 9 or whatever. And all of a sudden now you start getting hot flashes. It's not because the hormone replacement therapy is giving you hot flashes. It's because the natural history of your menopause transition is now you're in that section where you get hot flashes, and we may need to change your dose to get rid of those hot flashes. So for most women, unless you have surgery and have your ovaries removed, for most women, the ovaries don't just one day they're working and the next day they're not. There's this whole transition period that can last 7 to 10 years where things are fluid and they change. And so often we need to adjust the dose because what your ovaries are doing, what your body's doing is changing. So it is possible that you've never had hot flashes, you start hormone replacement therapy, and in a year or 6 months or a year and a half or whenever, all of a sudden you get hot flashes. It's not because of the HRT, it's because that's the stage that you've developed into. So that's the idea about that. So hormone replacement, except in the first few weeks, it's not going to make your symptoms worse that way. As far as dosing it specifically for specific symptoms, that's a sort of yes and no. So the truth is your ovaries are deficient in estrogen and progesterone and testosterone. So hormone replacement therapy is going to be replacing those hormones. Again, as we talked about the progesterone, mostly that's for uterine protection. It's the estrogen that's the heavy lifter, and somewhat the testosterone. So whatever your symptoms are, if this is from your ovaries not working as well, those are the hormones you're going to get. The dosage, we do vary based on symptoms. And so depending on what your cluster of symptoms are, does help us adjust the dosage and the specific medicine that we recommend. And so it is somewhat specific to your symptoms, but the truth is, lack of estrogen is going to cause hot flashes. In some people, it's going to cause brain fog in others. And so the answer is going to be estrogen if that's what your ovaries not making. But we do adjust not just the recommendation, but also the dose based on your symptom cluster I hope that answers that.
Okay, we have another question about the time. When is the best time to start HRT? So the question says, I've been without my period for 8 months now. Is it too late to start HRT, or is it best to start in perimenopause?
So what's the proverb? The best time to plant a tree is 20 years ago. The second best time to plant a tree is today, right? So the best time to start hormone replacement therapy is when you start having symptoms that are disruptive, so that we can get those symptoms taken care of. But just because you didn't do that last year doesn't mean you can't do it now. So if you're having symptoms, it's worth starting. 10 years after you've completed menopause, we really want to start it before 10 years are out. You're only 8 months in, since your last period. So you're still in that very safe time to start it. And if you're having symptoms, this would be a great time to start it. Would it have been better to start it a year or two ago? Maybe, but until I invent a time machine, I can't help you with that. So just because it might have been more beneficial to start it earlier doesn't mean you shouldn't start it now. So if you're having symptoms that are disruptive, this is something that can help you and make you feel better. And, quality of life is important.
That is true. Better late than never. That's the thing. Better late than never. Okay, one last question from Anne, who says, I'm new to Winona, just finished the questionnaire. I don't plan on taking DHEA, just the cream. Do I need to stop using for 1 week, like the BCP, to help prevent the blood accumulation inside my body? My period has stopped for some time now.
Okay, so yeah, no, you don't need to wash out medicine. And in fact, birth control pills, it depends on why you're on them. So hormone replacement therapy is not going to give you contraception. So if you need to prevent pregnancy still, then you don't want to stop your birth control pill because, again, we don't want to get rid of your hot flashes, but you have an unintended pregnancy. That's bad. And the HRT doesn't prevent pregnancy. If you're on birth control pills because you have really nasty periods and the birth control pills are keeping your periods regular or better, then it may be worth staying on them as well. We talked about that earlier. Hormone replacement therapy may help your periods a little bit, but that's not really the primary focus of them. And so if you're on birth control pills because someone started you on that for your HRT, doesn't work that great for hormone replacement therapy. This is one of my pet peeves. So there are docs out there that, again, aren't comfortable with hormone replacement therapy because they weren't trained on it and they don't really know how to do it. But they write birth control pills all day long for their younger patients. And so they just throw birth control pills at people because that's what they're used to. Birth control pills have a lot more risk and a lot more side effects than hormone replacement therapy, and they don't work as well at taking care of the symptoms of the menopause transition. So if you're on birth control pills because someone gave you that for your menopause symptoms, it's a poor choice, and HRT is going to work better. In that case, what I usually recommend is to stay on the pills for about the first 2 weeks of using the Winona medication and then stop the pills. It just makes that transition easier. So your body, hasn't lost the hormones and then it's trying to catch up with the new hormones. So a 2-week overlap, I think, is ideal if the birth control pills are being used for menopause. Again, if you're using birth control pills, for birth control or for cycle control, it's actually totally safe to take both. And so you get the birth control benefit out of the birth control pills and you get the menopause benefit out of the hormone replacement therapy. Even though they're both estrogen and progesterone, they're very different types of estrogen and progesterones that are really aimed at doing different things to your body. And so you can still get benefit from HRT even while you're on birth control pills. So in your case, it depends on why you're on the pill. If you're on it for menopause symptoms, I would recommend staying on it for the first 2 weeks and then going off. Or you might want to stay on it indefinitely if you're using it for contraception.
I think that's our last question. So,
all right. And what do you know? It's 5:30.
How did that happen? Almost never.
What a coinky dink. That never happens.
Almost never. Yeah. Thank you, Dr. Green, for giving so much helpful information to all of our all the people who asked questions, and to anybody else who still has questions, you can always reach out to us on our website. So, wait, am I seeing a last minute question? Hold on.
So yeah, I just want to say that the Q&As are great because you get to actually see me answer them, and the little, the answers are a little bit more fleshed out probably, but we're available on the me and the other doctors. We're very happy to answer your questions. So don't be shy about sending us a question in the portal. We want you to understand what's going on. This shouldn't be mysterious. It shouldn't be scary. We're very happy to sort of demystify things and try and myth bust, things. There's a lot of crazy myths out there about HRT, and we're very, me or whoever's your doctor, we're very happy to answer your questions online as well.
That's true. And ladies who are here, if you haven't, please feel free to join the Winona Women's Group on Facebook, because you can continue getting support there with other people who are also in the same boat that you're in, whether that's deciding to take Winona or just talking to other women who have menopausal or perimenopausal symptoms. And also, please, again, send us your questions and comments in the patient portal, because Dr. Green loves answering your questions, and all of our other staff enjoys answering your questions too. So please send them if you have them. And for current patients, we'll be back here in 2 weeks, and Dr. Green will be answering more of your most pressing issues as it relates to menopause. So join us. We'll see you guys soon.
Thank you. Care.